Hello, everyone. My name is Judith Agliam-Howard, and I am here today to talk about a case study on insulin overdose. The purpose of this presentation is to discuss what went wrong in this case study. Who and what role do other disciplines have in resolving the issues? I will also discuss a proposed solution and what barriers exist towards me implementing my proposed solution. Here's an overview of the case study. It is 3 a.m. on your call night. You are a senior anesthesia resident on call at a large hospital, and you have been working nonstop since 6:30 a.m. the day before. You have just finished a long surgery, and your beeper alerts you to a very sick patient from the cardiac ICU. You phone the surgery resident, and she gives you the following patient history. Mr. H is a 78-year-old gentleman who was admitted to the cardiac ICU last night for an active MI. On admission, his abdomen was found to be extended and rigid, and the surgical team is suspecting ischemic bowel, for which an immediate surgical exploration is warranted. Mr. H is intubated. His vital signs are currently stable and on several inotropes, and his kidney function has been getting progressively worse. You call your attending on call and assemble the team who will be caring for Mr. H. Several of the anesthesia residents work on getting the operating room ready, while another resident runs to the cardiac ICU to evaluate Mr. H and to obtain an informed consent from his family. You are keenly aware of the high-risk nature of this procedure. In your head, you quickly run through some possible worst-case scenarios in order to better anticipate complications. You discuss these with your attending and your colleagues. The patient arrives to the operating room, and the surgery begins. Soon after the incision is made, the diagnosis of ischemic bowel is confirmed. The patient loses some blood, and the decision is made to transfuse a unit of packed red blood cells. At the same time, labs are drawn, and soon after, your team is alerted to a dangerously abnormal result. Mr. H's potassium level is high, and his creatinine continues to increase, showing signs of further kidney deterioration. The high potassium is a cause for concern. A setting of worsening kidney failure and ongoing blood transfusion, Mr. H's body is ill-equipped to eliminate the excess potassium. With this in mind, your attending tells you to administer 10 units of insulin. You reach for the insulin vial and draw 10 cc's. You then attach the 10 cc syringe to the IV line and inject all of the insulin. You are stricken with the panic as you register what you just have done. You remember that each cc contains 100 units of insulin. You just delivered 1,000 units of insulin to an already compromised patient. What went wrong with this case? Well, a medication administration error occurred in this case. Mr. H, with several severe comorbidities, was undergoing abdominal surgery. The patient was administered the wrong amount of insulin. Several factors contributed to the medication error. Number 1, staff members, especially the senior anesthesia resident, had been working nonstop since 6:38 that morning and just finished up with a long surgical case prior to getting an alert about Mr. H. Number 2, the patient was a very sick surgical patient. Number 3, insulin packaging was not useful to the OR team. The insulin was packaged for subcutaneous use instead of IV administration. Not to mention, a 10 cc syringe was used instead of a 10-unit syringe. Other weaknesses to this case were communication challenges between the attending physician and the senior resident anesthesia. Assumptions were made about the medication order and not verified. Another weakness was the medication administration was not verified using the 5 rights of medication administration. It's the right patient, the right drug, the right dose, the right route, and the right time. Who and what role do other disciplines have in resolving the issue? How can it be resolved? The attending physician and the resident anesthesiologist must communicate clearly about expectation and patient plan. Anesthesiologists could perform a timeout prior to administering medication. Pharmacists can ensure the right medication and dosage is available to the OR team prior to surgery or available at all times. Registered nurse could be the second medication verifier and ensure a timeout or callout is completed before administration of medicine. The RN can also monitor and assess patient reaction to physicians and report to physicians and provide any interventions that are necessary. Surgeon and surgical staff can ensure safe surgical care. ICU staff can continue to monitor, assess, implement care, and notify physician of patient status. Together, all members of the healthcare team are essential to Mr. H's care. My solution to medication administration is to, number one, ensure all lines of communication are open. We'll conduct huddles or briefs before and after a case and discuss the plan for the patient and ensure every member of the OR staff is familiar with each other's roles. Number two, ensure the use of 5 rights of medication administration. Have another nurse do a second medication verification. All orders should be read back and verified. Number 3, perform a timeout or call out. Doing this has proven to re-engage staff members and ensure all members still have the same focus. Number 4, have the pharmacist prepare specific medication orders prior to surgery or have set medication orders available at the OR pharmacy strictly for surgical use, and anesthesia can color code their syringes to differentiate medications. Number 5, do a staff safety check of all members of the care team to make sure they are in the right mind and physically able to care for the patient in a safe manner. What are barriers that may interfere in implementing my proposed solution? That would be people's egos getting in the way of doing what's right, not wanting to do extra steps and ensuring patient safety. Some may say the steps are redundant and take too long or even say it's not their job. Another barrier to implementing my solution is staff members lying about their mental status and their physical ability in caring for their patient because of fear that they will be judged or lose their job. Thank you so much for listening to my presentation. I must say I really enjoyed this class. Take care. Bye-bye.